Welcome to another episode of Not Depressed, Just Unfinished. I'm very excited about today's topic, which is about ketamine and depression. If you've been depressed like I've been for many years, at a certain point you give up hope. There are many people in our society that they've been dealing with depression for a long time. So there has been research, experimentation, and practices coming from the field of medicine about use of ketamine to bring people, millions of people, hope and better lasting results. But ketamine has become a very controversial, interesting social media party topic. Today, we're going to put that all aside. We get to science. We get to data about what is fact and what is not. The doctor with me is an emergency medicine trained physician who made a pivot from the ER room to treating depression and mental illness using ketamine. So there's a story there. We want to find out why. He co-founded Ember Health in New York City, a physician-led IV ketamine practice and one of the country's largest practice. That's Dr. Nico Grundmann. Nico, welcome.
Thank you. It's a pleasure to be here.
We were going to get to topics. So Nico, in his practice, this is a good data. They have administered up to 40,000 ketamine through IV across the 5 offices in New York City since 2018. They have built one of the largest database examining the safety in IV ketamine treatment and outcomes. He leads research in partnership with Harvard Medical School, Massachusetts General Hospital, Baylor College of Medicine, and Stanford University, just a short drive from my house. And he's on the board of directors of American Society of Ketamine Physicians, Psychotherapists, and Practitioners. Before we go deep, I want to read a disclaimer. This podcast is for educational and informational purposes only. It is not medical or mental health advice, and you should not replace any care unless by your qualified clinician. If you have any questions or concerns, speak with your clinician about the outcomes best for you. Thank you. Nico, anything else about your background you want to share with us?
It'll come up in the story of how we got here, but I had a brief career doing international health work, which was part of the pivot to clinical medicine, which is part of how we ended up where we are today, having this conversation with the practice that we set up Ember Health.
Wonderful. So that's great. We will get to that. So I was imagining if I met you at a party, as a social gathering, barbecue. The question people, like when I tell about depression, I know what question people will ask. So ketamine, the very first question is that, what is ketamine? It has a very strange name. What is ketamine?
I'm happy to go into it. And I was asked to bring a prop, which is a vial of ketamine. These come in the boxes from pharmaceutical companies. This is a normal medication in the United States. The short story is ketamine's a medication that the US has been using for almost 60 years now. It was first synthesized in the 1960s, was first FDA approved in 1970. It first rose to prominence in clinical medicine as an anesthetic. The Vietnam War kind of claim to fame, where IV ketamine or intramuscular ketamine is really good at anesthetizing somebody, stopping them from being conscious. But unlike most anesthetics, it doesn't prevent you, it doesn't stop your breathing. It doesn't stop your heart rate. It doesn't cause low blood pressure, things like that. And so it rose to prominence because it could be used as a battlefield anesthetic, where patients have amputation, really severe injury, they could have that turned off, their consciousness turned off, and not feel the pain and be extracted from the battlefield or even be operated on. Unlike everything else we have anesthesia-wise, which would cause some significant complications if you get enough of it to not feel things. In modern medicine, in 2026, that's still most of ketamine's use. So these vials, their main use is in developing countries. Ketamine is still the single most used anesthetic globally, particularly in places that don't have the resources to do anesthesia gases or things like that. And even in the United States, its mental health use is still something like 10% of all ketamine use. The majority of it is in emergency departments and hospitals, operating wards. for that original indication.
Got it.
What it is in anesthetic originally, it purposefully separates, or it leads to a separation of the consciousness from the sensorium. So people are awake or people are thinking, but they're not perceiving anything input-wise from their body at the high doses. And then at the low doses, that's more blurry than it is a full distinction. And that started to be where we learned about its benefits for psychiatric indications or mental health issues.
So you were in the ER room and you saw ketamine. So what was it a pivot point or series of observation? Ketamine, ER, depression. How did that shift happen?
So with my emergency medicine hat, ketamine was being used for that original reason. I worked in a lot of level 1 trauma centers. I worked at pretty large institutions where we saw a lot of really difficult cases. And in a trauma context or in a pediatric sedation context, we'd reach for ketamine a couple times a shift. ER doctors tend to talk about ketamine a lot because of how useful of a tool it is. So, for example, a kid has a laceration on their face. That kid's never going to sit still if you're trying to sew that closed. So you can put them to sleep for half an hour. You can repair the wound, and the kid will wake up as the ketamine wears off and can go home without any more. So in that vein, I was very familiar with ketamine from my emergency training and clinical practice. And in a very different way, the emergency department is often where people with mental health issues end up. That was a very frustrating thing for me, where ER is where people go when they're suicidal or when they make an attempt. And even beyond that kind of penultimate need, people who are simply depressed, even if it's not a suicidal depression, will come to the emergency department a lot more often than people who aren't depressed. And so mental health is a really deeply underlying issue for all emergency department visits.
Sure.
And it was one that I was frustrated with. And so the short story of how our practice came about is that I had been seeing some of the clinical research, the academic data on how successful ketamine at very low doses, actually that's an important kind of your audience. These doses for surgery, these are almost 100 times more than people get in their mental health treatment. The blood plasma levels are wildly different. I saw that data. I was having conversations with my wife about if this works as well as the literature would suggest, why don't we see more clinics doing this?
Yes.
That led to a series of conversations where we thought that we might be able to help address that. And so back in 2018, we opened a pilot site. It was just me as the doctor. She was helping out. She had her other full-time job as a consultant. We treated our first kind of 100 or so patients. We saw that their clinical outcomes, their improvements in their depression, if anything, were better than the clinical trials would have suggested. They were doing well in rather life-changing ways. And that's what led us to both decide that this is what we wanted to do full-time.
That's right. So I have a comment here for the listeners and a question for you. So I used to work in the healthcare. And it is known in the healthcare that every day across the United States in primary care, up to 1/3 of visits are due to depression. So I was sitting across tables, the physician executives, doctors knew that. The question was, what do we do? You can't tell the mom or dad, they come and says, you may want to see a psychologist, psychiatrist. They called it functional illnesses. Test didn't show up anything. They look normal, but patient was struggling. So that to this day is an issue. We have such a prevalence of depression undiagnosed, and people, they can go for a long time living with that, and it shows psychosomatically, all sort of physical, body, and social, the emotional, the struggles. So you started your clinic.
Can I add to that? Because one of the factoids that really had me leaning into this space was that individuals who deal with depression are 3 times more likely to go to the emergency department for chest pain than if you're an individual without depression having chest pain. So again, you're going to show up to the ER, we're going to work you up for a heart attack because that's what we're concerned about. But the reality is that person wouldn't have come in if they hadn't been struggling with the depressive things. And to echo your point, it feeds into all aspects of American healthcare in ways that we should be better about addressing.
So Nico, let me digress for a second that These are known facts in the medical and psychological field. General population either doesn't know it or it's not being communicated in a way that is digestible, or instead of making it scary, that makes sense. Why is that? Doing such a gap, why is that?
It's really hard to disentangle something when 1 out of 10 adults deal with the issue. Major depressive disorder, a kind of clinical depression, as we call it, is quite literally 1 in 10 individuals walking around. It starts to just feel like the norm, and then starts to feel like a reality. And so when we start getting into health systems and population health and all these things, that becomes statistical talk. That becomes kind of things that are really different from the one-to-one clinician to patient relationship type stuff. And people aren't always able to judge or even tell themselves what's going on. It's not as if a depressed person is choosing to go to the emergency department because of that. It's that they're worried about their heart, or they're worried about what's going on. The challenge is that fear wouldn't have been present if they weren't. Yeah. But it's not like the person's making a conscious choice to do that.
That's right.
It's that we've put them in the society has put them in a situation where they don't feel the way that they should, and therefore they're not making decisions the way that we hope them to.
One of the things I'm learning in my practice, my clients typically are professionals, business leaders, all the way to C-suite leaders. One of the things I found out, showing data doesn't work. It's almost like people say, it's them, it's not me. I'm doing it very well. But the professionals, high achievers, they learn how to numb their depression. And it shows up in drinking, in addiction, overwork, and a sense of they don't feel their feelings. They're wonderful logical explanation, but they struggle to feel their feeling, and you can see that. So part of that, one of the reasons I do this podcast and my blogs is that don't write about depression, write about people's stories. You brought 100 people in your initial clinical trial to Ember Health. 2 questions. How did you invite them to participate? And B, did it work for them, and how?
So we didn't structure Ember as a clinical trial. That's actually an important distinction.
Thank you.
With people's permission, we collected data on how they did. We asked them to take surveys to try to quantify their depression, et cetera. But we baked all of that within kind of normal clinical care. The field of psychiatry is really advocating for measurement-based care as a term, trying to quantify things. And we leaned in on that and using things like the PHQ-9 to try to just say, this isn't my opinion that the person is doing better. This is what the patient has said on the score, and nothing has changed over time. When we opened, it's still the model we use today, where our framework was that this is different than what most psychiatrists do. And as opposed to expecting psychiatrists, psychologists, therapists to kind of retrain or go back to school or get licensed with the DEA to use controlled substances, that we could build a partnership model in a collaborative care framework. The easiest to jump to comparison is dialysis. There are dialysis clinics that do that. Nephrologists can do dialysis too, but it's often a lot easier to work with a center of excellence that focuses. That was how we started things. And so our patients are referrals. We see folks who have a mental health provider, a psychiatrist, a therapist, a psychologist. That provider is the one who diagnoses depression. I'm a big believer in perverse incentives. And so making sure we're not diagnosing it and then telling them how to get it resolved, that would be of interest. And at the same time, my teams have the skills that might not be normal parts of psychiatric training. We use low doses of ketamine, but it's still an anesthetic. And so there are still adverse events that are rare, 1 in 1,000 or 1 in 10,000 visits, like very rare, but they're not zero. And so we have the teams on hand to be able to make sure everything goes okay. High blood pressure, high heart rates, things like that are managed well by the clinicians who have the comfort in doing so. So getting the pilot site patients, the first couple hundred, was a community outreach. Back in 2018, people didn't really know about ketamine, or at least weren't using it clinically, despite that research. And our thesis on the main reason people weren't using it was exactly this, the kind of skills mismatch between docs versus those who manage mental health. And so I was knocking on doors and I was talking to psychiatrists and getting to know therapists and oftentimes dealing with the questions you're asking around what is this and why are you doing this? Papers from PubMed and explain, this is real, there's data. So you asked the question like, how does it work? Why is this something people think about? The fact that still somewhat stuns me to this day is that since ketamine was first looked at for its depressive improvement features, which was the year 2000 that the first clinical trial for ketamine for depression was. So in the next 26 years, we have more clinical trials on ketamine in that time frame than we do on Zoloft and Prozac combined.
Interesting. I didn't know that.
There has been, there are thousands of papers published on ketamine in PubMed. There are a couple hundred clinical trials that have been done. There are over 49, I think 50 RCTs, like large randomized controlled trial.
Okay.
The kind of highest threshold of evidence in medicine. Without putting on a tinfoil hat, the only reason this isn't FDA approved for depression is because it's a generic drug. The year that it was discovered to have its antidepressant effect. And so there's been no push of pharmaceutical industry kind of orientation towards getting it approved. And that's even more seen in that there's a bunch of ketamine derivatives that are going through the FDA's approval process. But the generic drug itself, despite how well it works, there's not really a financial interest in getting it through the US healthcare system.
Got it.
I'm not answering your question about how does it work. So from those studies, we talk about ketamine as having three distinct effects. So when I'm talking to a patient on an intake call, there's three things this seems to do. The first effect is that IV ketamine, the stuff in the vials, given as a slow 40-minute infusion at a very specific dose, causes regrowth of neurons in the brain. And it appears to be regrowing neurons specifically in the emotional reward regions.
The right brain.
Essentially, if you think of depression as the consequence of stress and trauma over time, being stressed, having trauma, prunes neurons, the depressive state. Ketamine seems to be undoing that prior stress and trauma related damage. That happens within hours to days. It's stunningly fast. And it's a result of all of the things that ketamine turns on, downstream growth factors in the brain. And there's, again, hundreds of studies and a lot of writing on kind of the why. The second thing ketamine does is what gets all the attention, which is that at the doses that lead to the neural regrowth, it causes an altered state of consciousness. So that's not a side effect. That's an anticipated aspect of patient care, is that people are going to be altered. They will be awake. They will be conscious, nonlinear. They will have very distinct psychological experiences when the medicine's in their body. What the studies have also shown is that those psychological experiences can be meaningful. The thing think about, the stuff that comes up in their thoughts, the emotions that they have, can feel very valuable. And it's very common to hear words like insights that they gained, shifts what they had, and that people take that. That's a distinct set of benefit from the regrowth that's going on that often becomes good fodder for psychotherapy and further work. And then the final aspect of ketamine is that neural regrowth is not limited to the emotional regions, but for several weeks after an infusion treatment, the brain is more globally. And so cool studies showing about adaptive learning during that plastic window. It's a fancy way of saying trying to change something, trying to change a habit, trying to change a thought pattern. And where psychotherapy has the best studied evidence post-ketamine, where psychotherapy becomes more effective than it would have because of the neuroplastic time.
Two things you mentioned. One thing I wanted also to clarify, you mentioned that your patients who come to your treatment, all or most of them, they also seen a therapist, correct?
We don't require psychotherapy in conjunction with, in that we work with a lot of patients who may have been in therapy for 10 years, 20 years, and decided it's not for them right now. But we encourage psychotherapy. And the number is something like 70% of our patients have a therapist.
Got it.
Now, I do want to clarify, we do require a mental health provider. So if they don't have a therapist, they do need a psychiatrist or a psychologist or a primary care doc who's specifically managing their mental health. So mental health provider, just not necessarily a therapist. That's a patient choice, not an us choice.
Thank you. This is helpful. You also mentioned the PHQ-9. For the listeners, this is the standard template for assessing depression. If you go online, do PHQ-9, Patient Health Questionnaire 9. There are 9 questions. Yesterday, I was doing my annual exam, and my primary care doctor says, Arashir, I need to ask you this question. We sat through them. I said, I'm a psychologist. I know how to answer them. So you go through them, but you can basically see what are the standard ways of tracking depression. This psychiatrists use that. 3 things you mentioned about what ketamine does. It helps about regrowth of neurons between the brain and especially left and right lobe, that they will have some level of alternate state of consciousness. Things, you experience things, you have memories come up. And the third one, this experience is not just during the infusion, lasts for several weeks, that the regeneration, neuroplasticity.
Small point of clarification. The experience, in terms of the altered state, we make sure that's over before you walk out the door. So that experience is short. The neuroplastic window for a couple weeks. I don't want people feeling nervous that they're walking around altered in long periods of time. They're not.
Thank you.
There's a whole clearance process to make sure that you're safe to walk out the door.
Thank you for that clarification. The reason this matters, that for folks who have been depressed for a long time, one of the ways you see that, and it shows up in PHQ-9, is the lower level of feeling, flat affect. And in fact, in the CAT scan, you see the left and right brain lobe, the before and after treatment, that right lobe started to more blood and more energy. So what this medicine does, it seems trying to create better interaction and also re-engage, boost the right brain, which is about when you're hurting, we don't want to feel anything. That's what I see a lot of leaders. Wonderful. They can discuss their feelings, explain it, but they cannot feel it. Their body's flat. All you know is heart racing, tight gut. It's coming up. So, Nico, who benefits from the ketamine treatment? Do you take anybody, or who are the ideal clients?
So there's 2 parts to the answer. There's the kind of medical, legal, regulatory side of it, and then there's the usual words, the kind of real life individuals, the stories. Medically, it's actually pretty straightforward. So it's clinical depression are the patients that we treat, individuals dealing with that. To use the terms, it would be something like major depressive disorder, that DSM diagnosis. We'll also work with individuals with bipolar disorder when they're in the depressed. But really one of those 2 labels. And the reason for that is that's all the trial data. When we look at the studies, all of the studies have participants who went one of those 2 diagnostic categories. Now, there's an aspect of ketamine that has changed in the last 5 years, but originally this was looked at for treatment-resistant depression. The air quotes, because I really don't like that term. That used to be defined as 2 or more medication failures for the depressive episode. And so basically these people were depressed. A provider had tried 2 different medications like Prozac, Zoloft, etc. Those had not led to success, and only then was ketamine used. That's where most of ketamine's early history really focused on. And even today, most of the studies are specific to treatment resistance. More recently, what's become clear is there's nothing magical about 2 medication failures. That people who are depressed will often do well with ketamine, even if they don't have to wait that period of time and try the other meds first. So our clients, we don't require the treatment-resistant component of this. You'll notice I'm not saying things like PTSD, anxiety, and there are clinics that do ketamine treatments that really focus on those other issues. My stance is that while I hope those things pan out, the literature in terms of published understanding for this hasn't yet had the volume of papers for those other mental health indications that we would to do this, particularly at the large scale that we're doing it at Ember. Many of our clients deal with all of that. Depression, you probably also have anxiety, our patients, and that's absolutely fine. Those are very good candidates for ketamine. You can have depression and a comorbidity, so to speak, and anxiety, depression, and PTSD. That's the norm, in fact. But if somebody had only PTSD with no depressive symptoms, they would not be somebody that we would recommend for treatment.
Got it.
To answer the second half of this, okay, just MDD and bipolar, again, that's close to 1 in 10 adults, if not 1 in 10 adults. And that doesn't really help clarify who should be getting this. This is where we talk about patient archetypes, or kind of common ways that patients present themselves and the stories they tell. Roughly 1 in 4 of our clients at Ember are an archetype around difficult to function depression. You can't hold a job, in and out of hospital, often pretty heavy care-seeking people, a lot of healthcare interaction. And that's ketamine's kind of prototype of where this was first looked at, and that's where it can be unbelievably successful. Regularly hear people talk about how they can get out of bed, how they can hold a job, how they can actually function, they can feel, they can participate in their own lives in the ways that just weren't possible before treatment.
So they start to feel more alive, more energetic, more present versus depressive feeling that I'm sinking. You just feel you're here. You have more energy.
Energy is a big part of it. Motivation is a big part of it. The inverse of apathy, the inverse of those things turn off and you go back to feeling your full range of emotions. Talk about that because that's not always a inherently positive thing. Emotions are complex. You can feel negative emotions even when ketamine works. The situation warrants it, but you can feel everything as opposed to feeling nothing, the way that a lot of those people describe. I often emphasize the kind of second, or the 60% of the people that we treat are the ones that you're referencing in the sense of usually actually quite highly functional individuals. A lot of clients who are senior executives, who are mental health providers, a lot of startup people, a lot of hedge fund managers. New York, where the city is a stressful place. And for those individuals, they might not even identify as being depressed, to your point earlier, where often they're more trying to match the kind of knowledge of their success, their family relationships, the goodness of their life, intellectually talk about, but that they don't feel.
That's right.
And that is depression too. That is also clinical depression. It's just not necessarily the way that the TV shows talk about it.
That's right. That's right.
And so we'll treat both. And in fact, we'll do our own assessment. We'll make sure that the collaborating team agrees that it's depression. But depression looks really different for different people. And I want to emphasize that ketamine as a treatment works for all comers, if that label applies.
So clients come to you, your team does initial assessment, baseline, PHQ-9, general health, how they might respond to ketamine. I'm sure there's orientation, what it looks like. What is the patient experiencing during that time?
So to walk through a normal visit, our office visits are roughly 90 minutes long. Extremely short, given what we do and how people talk about this. And the medicine itself, to your point, is only 40 minutes of treatment. That is, this liquid goes into a bag of saline, it gets hung up on a pump, it runs through a computerized pump into an IV for 40 minutes. And we're in the room all the time, we're actually sitting next to the patient the whole time. But in our care at Ember, it's a 1-to-1 patient to clinician ratio. So one of our doctors or one of our nurses is with that person in that room. If we can, we'll pull up some pictures for the podcast of what the treatment rooms look like, because this doesn't look like a normal doctor's office. We know they're going to be altered. We know that can be disconcerting. And so we're not walking around in lab coats. We're not.
I saw that. It looks it's almost like a massage place. It looks great. I want to go there.
And it's a balance because we want people to feel comfortable. We want the environment to be supportive, understanding the psychological impact of that altered state.
That's right.
And we want people to recognize that we're emergency medicine doctors and nurses from ICU care, and that we're doing all the evidence-based stuff, but we're not making people have a false choice between following the science and doing it in a comfortable way.
So they're conscious, correct?
So the doses we use for mental health, the kind of very specific range that this helps depression at, are doses where the person can talk. The person is awake, they're conscious, they can interact with the world. They'll be altered, they'll feel different than they do, but it's not an anesthetic dose. It's not a put them to sleep. How to describe that experience is a career's work. And there's never one single way to talk about this because each person, much less each visit, is going to be a little different. As you referenced, we've done 42,000 of these infusions at the practice. We've done a lot of them. And we talk after every visit. So there are commonalities in how people describe what that's like. Called the archetypes of the experience, there's a couple. One is that some of these sessions can feel very strongly like a quieting of the mind. You're awake, but there's not a lot happening. For clients who meditate, that can sometimes feel like a cheat switch for meditating, if you will. And it can be quite scary for folks if they're not used to that quiet space, or if they're not thinking that that could be where their thoughts go. It can be a nice place to be, but it's often very different than their lived experience today. There are other sessions that are much more reflective. We hear these very colorful stories about people flipping through chapter books of their own life, looking at old memories, turning about something else.
There's more recall.
And it's recall that has associations with whatever they've been going. There's a story of a client picking up snow globes of their childhood and looking at them, letting the snow fall down and then putting that down and moving on. There are sessions that really help grant perspective on issues. We talk about kind of people looking over their own shoulder. This comes up a lot with clients who have trauma backgrounds, where under the influence of ketamine, they might be able to think about that trauma without the emotional activation that normally they can be looking over their own shoulder. They can recognize that it wasn't their fault. And normally those emotions, that memory might have such significant emotions associated with shit that they can barely get near it, much less spend time and sit with it. And then there's also this kind of vivid dreamlike state that can be pretty characteristic of this, where it's when ketamine is active in a person's body, their brain is what's called an associative thinking state. This memory is connected to this memory is connected to this thought. And it's a little bit like dreaming in some way. In the moment, it feels like you're just following along with where your thoughts go. And afterwards, you might have a hard time making a coherent narrative out of it. The thing I want to highlight, though, is that all of what I just talked about are examples, but each person, each visit is going to have a different experience. Their brain is, what comes up for them will be unique. And a lot of the job of what we do in the office is to make sure that no matter what comes up, that person feels okay. They feel safe, feel supported. We do have stats on that. So roughly 5% of treatments are described as psychologically difficult, even with all the stuff that we do. So we'll have a person in the room, we'll set an intention, we'll pair that intention to music therapy, we've got aromatherapy in the room, these comfortable environments. Even with all of that support, 1 out of 20 of these are still hard. And that's not inherently bad. Most people don't go to their therapist to talk about the good stuff. It's a similar framework here, that just having a difficult experience or thinking about things that are unpleasant or difficult isn't inherently a negative thing. But you really want to make sure that person feels supported through that process.
This 4 area you mentioned, that basically is the augmented brain emotional processing, looking at the past, looking at the emotions, the reflections, quieting of the mind from the monkey brain. Is there a place for journaling, capturing about how does the integration during the visit happens before they go to their day jobs?
So there's a lot of research trying to give an answer of what's the best way to do all of this. And the reality is right now, we don't have a single thing that's correct for everyone. Our stance at Ember is that you let the person have their experience unless they want to engage during that with you. So we're in the room, we stay there sitting. And if the person is quiet, if they're lying back comfortably, we let that be. And then if they want to talk, if they want to take off the headphones and try to engage, we'll do so. But we're not going to be prescriptive on that. There. Once the treatment is over, once the infusion is done, we give people roughly 10 minutes, which clears most of the pain, and they can then talk and engage pretty much relatively normally. And then our teams are all trained in holding the space, to use that term. We basically have open-ended questions, help people start to turn the gears around what felt important, what felt significant, what they're feeling now. And there's a whole set of stuff we bring our staff through to give them comfort with that. It's not necessarily normal medicine training. And then we give patients agency. Every one of our patients is given a journal on their first visit, told that it's not required, it's not homework. If they would like to, it can be a good tool to capture things. Sometimes patients don't want to talk after their session. That's okay too. We don't force them. We give them a choice to. But we know that each person's going to have a different way of taking that. And then again, we advise psychotherapy. Some of the best trial data is not therapy when you are altered. There's actually almost nothing published that would support that as a thing you need to do. A lot of data on therapy in the days and the weeks afterwards. That does appear to be helpful and augmentative. And so we'll collaborate with a therapist. We'll make sure the patient is engaged that way.
So the patients come to you. What is your take on the other medications might be taken, SSRI? Can they continue? Should they stop? How do you guys approach that?
The highest level answer is that we do our own assessment. Our doctors talk about that for each patient individually. But as a framework, ketamine is safe to use with other medications. There aren't medication interactions we're worried about. That might be very different than other psychedelics that are being looked at in research trials. You have to be quite careful about SSRIs and other things that have serotonin. Ketamine, those aren't of a concern. There are some medications that might make ketamine less helpful for depression. Things like benzodiazepines, naltrexone. There's a couple of drugs that have weak evidence of interaction, and we're actually publishing on that with our own data. Nothing that would prevent you from seeking care, more just talk about medication guidance. And the point to highlight is that for our practice, for Ember, we're not going to take over those prescriptions. We're going to be having that conversation with the patient, and we're going to be having that conversation with their prescriber, so that the prescriber and us can make an informed collective decision on what's going
so the patient doesn't have to get in that. So let's talk about what's the social media sensation. With Matthew Perry, Michael Jackson, there's some story that they seem they live. So what's fact and what's fiction?
Before we dive into that, I do want to clarify one thing for folks, in that when we talk about ketamine treatment, there's really two parts of treatment, and people sometimes mix that up. The treatment really is the first 4 visits, the first kind of induction series about finding out, does this person respond to ketamine? It's like a 75% treatment success rate or an 85% treatment success rate. They're really talking about 4 out of 5 people feel better from the first 4 visits, and that their depression goes away or markedly improves. If a person feels better, then there's a whole second set of stuff about maintenance care. Like, how do you keep them feeling well over time? And this will involve repeat visits. This will involve some degree of continued interaction. And our clients, it averages once every 6 weeks that we see folks for a treatment session. But when you talk about social media, which we'll dive into here, this is not something that people have a ketamine treatment and then never feel depression ever again in their lives. That's a myth. No studies have ever shown that. No patients ever really feel that. You might go a very long stretch of time feeling well. The people we treat will go over a year before they come back to us. But 1% is not the norm. 1% is the exception. Most patients come back in a couple of weeks because their symptoms start to come back. Basically, the ketamine doesn't prevent them from getting depressed. It resolves the depression when it's happening, but then their lives would be stressful. They still have to process that trauma. Those things can recur.
That's right.
You asked about social media, so please.
No, just to hear that Matthew Perry, there was an article in the New York Times, and Matthew Perry died of a ketamine overdose. And you hear about Michael Jackson, and there's some public figures as well. So what is truth, and what is the misuse And when people, and what happened those that is gets used like that?
So situations like the Matthew Perry one are just tragic. Matthew Perry had a lot of substances that he misused over the
Mm-hmm.
a big part of his book that he published right before his death. And in his case, as an example of this, Matthew Perry drowned in a pool after being given more ketamine than you would use in anesthesia. So he was getting daily injections of ketamine by his assistant at home. And all 5 of the clinicians and people involved in Matthew Perry's ketamine use are in jail. It wasn't a normal use situation, a really significant diversion, misuse, and abuse, unfortunately. Ketamine is not a perfectly safe drug. There's a reason I have a doctor in the room for each one of these treatment sessions. It's a very safe drug, but like anything that's a anesthetic, it can be dosed wrong, it can be dosed correctly and still have a issue with heart rate, with blood pressure. The FDA has been very firm that the only thing we should be receiving is under clinical supervision.
Yeah.
They put out a warning to that effect in October of 2023, given the kind of rise and prominence of this treatment in the US. Like anything that alters your consciousness, ketamine can be misused. People sometimes want to seek an altered state, and anything that causes an altered state is a medication or a molecule that can be abused from that. When people misuse ketamine, though, it looks very different than medical ketamine or medical use of ketamine. So this has been well studied in the UK, has a ketamine abuse issue in its adolescent population, where people end up using multiple grams of ketamine a day. And when people start getting these scary stories about bladder issues or cognitive issues, those occur with a high dose daily ketamine use. The more you use ketamine, the more ketamine you need to be altered.
Because the substance abuse.
Exactly. To give context to that, when we use ketamine for mental health indications, the average dose ends up being something like 40 milligrams. And again, our patients come in on average once every 6 weeks. Translating to caffeine, which many people can think about more easily, it's like the difference between having 1 cup of coffee every 6 weeks versus drinking 200 cups of coffee every day. The same drug, very different doses, very different frequencies. And all of the consequences people worry about with abuse, which are real, are take a lot of it every day. So this is where it's so important to contextualize what's going on, to recognize that it's very good. It is the single best thing we understand to help address depression. It's got its potential for misuse, which you have to build frameworks around.
That's right. In fact, we all loved Friends, the TV series when they came out. So when I read that article, Matthew Perry's article in the New York Times, a year before his death, his psychiatrist, actually the term he used, clean bill of right from depression, said that he's healthy. He wasn't. And how that was missed, to me, that's malpractice. And wonderful actor, beloved actor, he was in pain, emotional, physical pain, and he was, as you said, taking multiple medication. So this is when you rely on something that is meant to be for health. You're trying to numb yourself. In clients, at times, that people who they drink a lot. After I worked with this wonderful executive, they go after work for business meeting, and I was seeing how many drinks gets ordered. So it's the same thing. It's about when your pain is there, emotional pain, how do you actually address it versus numb it? So
this is where the issues come up, is exactly what you're getting at. There are very few things that give you distance from your emotions as much as a medication might. And that can be a really difficult thing for people who have addiction personalities or people who need to numb themselves. And as you mentioned, a bunch of other things will let people numb themselves. Alcohol is a really significant issue in the country.
Yeah.
And so it all becomes questions about context, about fit, about safety structures. For example, our patients at Ember, they don't have access to ketamine outside of our office, and we don't let them. We administer it. It's in our safe. It's something we give them when they're here, And we have policies that if we learn about ketamine use outside of our offices, we stop care. We'll talk about that with them. We'll make sure that they have the support structures in place, but we'll make sure that this is not something they're doing with us and then also doing elsewhere. That would become potentially dangerous and let's stop working for their depression. But we have to put all of this kind of thought into place to make sure that people are supported
going forward. So Nico, for listeners who get interested, they want to learn more about ketamine, what should they do?
So as you mentioned, I'm a board member of the American Society of Ketamine Providers. There's a national conference they host every year in January. I'd highly encourage kind of interested people to attend. You get a lay of the land, you get to meet fellow providers. It's a really nice resource. ASKP also has webinars and trainings for folks. If you're in New York City, I'm around, so don't be shy. We run lunch and learns, we do social events, we get to know the community, and it's a really nice way to start to think about this as an option for patient. And honestly, I wouldn't be surprised if this trend nationally continues. We across the US, much less the world, that things will have to change as we go, and that treatments like ketamine or things that help with depression are only going to become more and more standard of care, continue to have people suffering. And so educate yourself. There's online courses, there's groups like I've talked about, there's webinars, and there's also clinicians that do this. And so don't be shy about making those connections in that community.
Wonderful. What is one takeaway you want our listeners to have from our conversation?
I think the biggest thing is stuff that we've hit on a little bit so far, but the recognition that with ketamine, the details really matter. The route of administration really matters. Everything I've just been talking about with you is about IV ketamine, slow infusions in office. And the outcomes are completely different when you look at oral ketamine or intranasal ketamine or intramuscular ketamine. Those don't have the same numbers or success rates. And specifics of treatment make a big difference. The doses matter a lot. Low dose ketamine, really good for depression. Anesthesia ketamine doesn't do as much for depression. And so the details of the clinical situations are ones where it's not just a medication that works equally for everything all at once. It's where nuance makes a big distinction. And it's why I would suggest working with groups that have familiarity with those nuances. Does drastically change the success rates.
This is great. Nico, thank you so much for our conversation. Your information, multiple URLs will be in the body of the blog and on YouTube for people to learn more. As you said, there are two messages I want you to remember: that depression can be healed. For somebody who came from a family, mom and dad, siblings depressed, and learned and clawed my way out of depression, can be healed, and that healing can accelerate. And so ketamine is one solution, can provide option, can provide basically a booster for your healing. The outcome is less suffering and not taking depression as a life, as fate. And also what Dr. Nico Grundmann mentioned, get to know the facts, go to the science, get to know the essence and decide what's right for you. So really start with the basic science, and the end goal is you feeling better, living better.
I'd echo everything you just said, and I'd also highlight that ketamine is never the full story. But this is really the best tool when embedded within a larger framework for helping somebody. It's not a silver bullet, it's not magic. It helps a lot. It makes a fundamental improvement for the folks that go through our care. But that is improvement with the support of the rest of their care team, with additional work that they're doing outside of our offices, continuing to try to improve their own lives, and having that agency back to be able to actually do that work in ways that are difficult to do when you're stuck in bed.
Wonderful. Thank you so much, Nico. We'll talk again.
My absolute pleasure. Thank you.